Hi, I'm Mahela. I'm doing my project on the donor program here at Baptist Health Deaconess Madisonville. So our program was established in 1961 here in Hopkins County. In 1986, our mobile donor program was established, but it's since been put on hold due to COVID and now lack of staff. We pretty much only do whole blood allogenic donors, just because we don't have very much of a population for anything else. Donation process, so the donor will come in and we'll start them with getting them registered. We take their photo ID, most of the time driver's license, and we put that into LifeTrack, which is what we use for our donation process, and it will pull up all their information. If they've been here before, if they haven't, we have to of course enter it with their ID. We'll get their full name, their address, a contact number for them, their age of course. Of course all donors 16 and up are able to donate, generally 16 with parental consent. We only accept 17 and up, so that way we don't have to worry about getting the parental consent. Let me see. We also get their date of last donation, which would be, since it's whole blood, at least 8 weeks. We give them the education material, which would define eligibility, as well as give them examples of risky behavior and symptoms of HIV. So the donation process then starts. We give them a list of medications that will be deferred, so that way they can go on and let us know, hey, I'm on this medication. We'll let them know, it tells them how long they'll be deferred for. If they aren't on any of those medications, we go on and let them do the health history questionnaire. So that's about 43 questions. It will ask them about, medications, their health history, such as like pregnancies or previous diagnosis, or if they're involved in risky behavior. So that will let us know if we need to defer them for another reason, such as like if they've had leukemia, or if they are a sickle cell patient. Obviously they're permanently deferred. 3-month deferral if they've gotten like a tattoo or a needle stick. Malaria, if they visited an endemic area, then they'll be deferred for 3 months. If they lived in that endemic area, they'll be deferred for 3 years, so on and so forth. Physical findings, so we'll take their blood pressure, respirations, pulse, their hemoglobin, we'll get their weight, and temperature. So temperature, they have to be below 99.5 degrees Fahrenheit. Pulse has to be between 50 and 100 beats per minute. Blood pressure between, systolic is between 90 to 180 and diastolic 50 to 100. Hemoglobin for men has to be between 13 and 18.5, and for women it's got to be 12.5 to 16.5. The weight, we require 115 pounds. I know the minimum requirement is 110, but we require 115. We also ask them when their last meal was. If it was within the last 6 hours, we don't require them to take a snack from us, but if it was not within the last 6 hours, we require them to take a snack. We'll also look at their general health. Do they look healthy? We'll check their arms, make sure there aren't any like track sites or anything like that. And then we will obtain donor consent. This is a copy of what we give them. It's got everything except for where they need to sign, but it just goes over, yes, I consent to having to draw for, yes, I consent to you all drawing my blood. I consent to you running all these tests on me. I consent that I have not been involved in any risky behavior, so on and so forth. Okay, so now we start the phlebotomy. So of course you'll find the vein. We do a two-step iodine clean. Of course we confirm with the donor that they are not allergic to iodine. So long as they are not, we take the first swab and scrub it really good. Throw that away, grab the second swab of iodine and start in concentric circles, starting from the site and going out. Once the site is clean, you obtain a new bag and a donor record card. Tie the tourniquet, begin the venipuncture, and label the donor record card with the unit number that's on the bag that you just used to stick them. You record time that the blood starts flowing. So once the blood is flowing and the time is recorded, you can fill up that diversion pouch. Once it's filled, break the Y seal, so that way blood will flow into the main collection bag, and then clamp off the diversion bag. You can then fill your pilot tubes. The 3 pinks and then 2 golds will be filled from there. Periodically mix that bag. Once those tubes are filled, just mix the main collection bag to ensure no clots form. And once the main collection bag drops from the scale that it should be sitting on, you're good to stop phlebotomy. You can seal off the main collection tubing and document time. And then, of course, remove the needle, remove the tourniquet, remove the needle, apply firm pressure, tell them to hold their arm above their head. You're going to want to take care of that bag as soon as possible, but never leave the donor side. Okay, so here are some pictures. Here's a picture of our donor collection bag. Just before it even begins, I didn't want to open it because I didn't want to mess it up, but here is a picture of our scale with nothing on it. You can see it's tilted up, and then with a full bag on it, it tilts down to let you know that it's completed. Alright, so if the collection time, because remember you document start time and end time, if the collection time was greater than 15 minutes, platelets and fresh frozen cannot be made from that unit. So you're going to want to document that and place a sticker, an extended bleed sticker on the unit, so that way anyone who is processing components will know to not make FFP or platelets. You're just going to want to double check all the unit numbers match everything that was collected on that donor. Encourage the donor to drink, eat a snack, so that way, of course, decreases the chance of them having an adverse reaction. And encourage them to stay for 15 minutes. We require them to stay for 5. However, we would like them to stay 15. Then you're going to want to fill out this donor card for them. It will give them the date of when they can next come and donate blood again, their unit numbers. That way, if they need to self-exclude, they can. It gives our hospital number all the information they need to self-exclude. We also give them all of their vital signs, so like their blood pressure, their hemoglobin, their pulse, their temperature, just so that way they can have that known. It's also helpful for if we have to defer, they can see why they were deferred. Okay, so blood donor reaction. First, of course, we want to be able to recognize this. So it's vasovagal. We want to check for weakness, pallor, sweating, dizziness, loss of consciousness, obviously. And if, of course, you recognize any of this, you're going to want to stop the phlebotomy immediately, release that tourniquet, remove that needle, apply pressure, take care of the donor pretty much. If they faint, you're going to want to tilt them back in one of our donor chairs back here to where their feet are above their head. Apply cold compress, make sure nothing's obstructing airway. If you have to, give them a little whiff of ammonia. That should wake them back up, and if it doesn't, at least run the hospital so we can get them to the ER. But fainting, nausea, vomiting, hematoma, if hematoma forms, of course you're going to want to stop. Apply extra pressure, maybe 10 minutes instead of the 3 to 5. And then you're going to want to document. So in our SOP, it gave us a donor severity grade for their reaction. I've never had a donor actually give an adverse reaction. I have had an adverse reaction myself, but it was only a level 1, so there was no need to document or anything like that. Most reactions are just going to be level 1s, which are mild. Unit processing. So blood donor's gone. It's just us with the unit now, so we're preparing components. So red blood cells have to be separated from whole blood within 6 hours of collection. Gotta place the whole blood in the centrifuge and balance that. If you were making platelets and FFP, you want to do a soft spin, so a low gravity force spin. If you were not, though, you can go on and do a hard spin, but it really isn't going to be that big of a deal. So you're going to want to take that spun bag of whole blood, so the centrifuge separated whole blood, put it in the plasma extractor, release that spring so that way the plasma can be extracted, and plasma will be forced out into another bag, satellite bag, and once it's going and you just barely start to see red cells come up out of that, you're going to want to clamp it and then heat seal it to prevent flow back and forth, pretty much. Okay, so once you heat seal it, you're going to want to remove the plasma bag from the red cell bag, and on the red cell bag there is an attached adsol. So you're going to want to hold that adsol above the red cells, unclamp, and let the adsol flow into the red cells. And the adsol has to be added within 24 hours, so that way it can increase the expiration date to 42 days. Here's a picture of our plasma extractor and then our centrifuge. You would put the unit in between the plastic and then the white, and that would push back on it and force the plasma out the top of the bag. Okay, unit processing. This is small text, I'm so sorry. But when platelets are made, if platelets are made, you're going to want to spin that platelet-rich plasma bag again, this time with a hard spin, so that way the plasma and the platelets can separate out. Once it's spun, you're going to want to take that platelet-rich plasma, put it back in the plasma extractor, extract the plasma. You're going to want to leave a little bit of plasma in there, just that way it's not straight platelet. And then you're going to want to seal that tubing to separate out the two separate components. And then you're going to want to cut that. FFP will be frozen at negative 18 degrees. If you're not making platelets, then you can just keep the plasma the way it was whenever it was extracted from the red cells. And all components we need to ensure that we're labeling all components with the same unit number, everything. Okay, unit processing still. This is red blood cell leukoreduction. So what we'll do is we'll take that red cell bag with the adsol, and we're going to want to leukoreduce. So we're going to connect our leukoreduction filter with a thermal weld. Back here, I know it's hard to see due to the way I'm presenting, but I have pictures of our thermal welder that we use, and we're going to want to weld that together, make sure the weld is good, take it to the fridge and hang it so that way it can filter by gravity. And we take it to the fridge because it filters best at like 3-ish degrees, so that's where we do that. AABB standard leukoreduction, you need to retain 85% of the original red cells while leukoreducing to a maximum of 5.0 times 10 to the 6 white cell count. Okay, donor testing. So all donors are tested in-house for ABO-RH, as well as their antibody screen. If they are Rh negative, we perform in-house week D. All other tests we send to Western Kentucky Regional Blood Center, so that way they can be ran by FDA and AABB approved methods for all of the following. Syphilis, which is RPR. We run HIV, hepatitis B virus, and hepatitis C virus by nucleic acid. We also they run hepatitis B surface antigen. They run HTLV 1 and 2, as well as nucleic acid testing for West Nile virus, and they also do testing for Chagas disease. Then here are my references. Thank you.